According to the Alzheimer's Association, someone in the United States develops dementia roughly every 66 seconds. That's a real widely cited statistic. What gets talked about far less is that for some portion of those cases, age may not be the main driver at all. Sometimes it's a medication sitting in the bathroom cabinet, one that was prescribed with good intentions, filled at a pharmacy, and never questioned again. Today, we're going through 9 medications that geriatric research has studied in connection with memory and cognitive decline in older adults. Not to scare you away from anything you're currently taking, but so you know what questions are actually worth bringing to your doctor. I want to say this clearly before we start, because it matters more in this video than almost any other. Nothing here is a reason to stop or change a medication on your own. Several of the drugs on this list can be genuinely dangerous to stop abruptly. Every single one of these is a conversation for your doctor or pharmacist, not a decision to make alone after watching a video. With that said, let's count down from 9 to 1. The medication classes most discussed in geriatric research for their relationship to memory, ending with what may be the most overlooked risk factor of all. Not any single drug, but the combination of several at once. Before we start, I'd like to hear from you. Tell me your age in the comments and whether any of these are familiar to you. I read every comment, and it shapes what gets covered next. One more thing worth saying up front. Every medication we discussed today was prescribed for a real reason, by a real doctor, to address a real symptom. Nothing here is a suggestion that any prescriber did something wrong. This is about staying informed as a patient, not second-guessing the medical system. It is also worth saying that medication side effects being mistaken for normal aging is a recognized, real phenomenon in geriatric medicine, not a fringe idea. Doctors themselves often describe this as one of the harder patterns to catch, precisely because both look similar on the surface. Number 9. First-generation antihistamines, diphenhydramine, sold as Benadryl, being the best known. It's inexpensive, sold without a prescription, and used for allergies, colds, and occasionally as a sleep aid. Diphenhydramine belongs to a class of drugs called anticholinergics, medications that block a brain chemical called acetylcholine, which plays a central role in forming new memories and staying mentally alert. As the brain ages, it naturally produces less acetylcholine and relies more heavily on what remains, which is part of why anticholinergic drugs are generally considered to affect older brains more than younger ones. This class of medications appears on the American Geriatric Society's Beers criteria, a widely used formal list of medications considered potentially inappropriate for many older adults, largely because of this anticholinergic effect. Research in this area has associated regular, long-term anticholinergic use with a higher relative risk of cognitive decline, though the size of that risk varies across studies. In practice, this means it's worth checking labels on anything described as nighttime, PM, or allergy relief, since many contain diphenhydramine under a different name. Newer antihistamines such as loratadine are generally considered to cross into the brain far less and are often discussed as gentler long-term options, though again, any change is a conversation for your doctor or pharmacist, not a decision to make solo. It is worth knowing that occasional use, an antihistamine for a single bad allergy day, or a rare night of trouble sleeping, is a very different picture from nightly, years-long use. The research concern here is almost entirely about sustained, regular use over long periods, not occasional reach for the bottle. A practical alternative worth knowing about for occasional sleep trouble: good sleep hygiene habits, consistent bedtime, a cool room, limited screens beforehand, address the root issue for many people without any medication at all, anticholinergic or otherwise. None of this requires memorizing drug names. A simple habit, asking your pharmacist directly whenever you pick up a new over-the-counter product, "Is this one considered anticholinergic?" takes only a moment and covers this concern reliably going forward. Number 8. Proton pump inhibitors, omeprazole and esomeprazole among the most familiar names. Prescribed widely for heartburn and acid reflux, often for years at a time. These medications reduce stomach acid, and stomach acid plays a role in absorbing certain nutrients from food, including vitamin B12, which supports nerve and brain function, along with magnesium and calcium. Some research, including a large observational study published in JAMA Neurology, has found an association between long-term PPI use and higher rates of dementia diagnosis in older adults, though observational studies like this show correlation, not proof of direct cause, and more recent research in this area remains mixed. This doesn't mean PPIs are inherently dangerous. For many people, they're genuinely necessary. It means that long-term, indefinite use without periodic review is worth revisiting with a doctor, particularly to check B12 and magnesium levels and discuss whether the lowest effective dose, or a different approach entirely, might make sense for your situation. It is also worth knowing that stopping a PPI abruptly after long-term use can sometimes cause a temporary rebound in acid production that feels worse than the original symptoms. This is exactly why any change here should be gradual and planned with a doctor, rather than stop suddenly on your own. For milder, occasional heartburn, some people find that smaller changes, eating earlier in the evening, reducing specific trigger foods, elevating the head of the bed slightly, meaningfully reduce symptoms without needing daily medication at all. Though this varies a great deal by individual and by how severe the underlying reflux is. A yearly review specifically for long-term acid reducers is a reasonable habit to build into an annual checkup, simply as a standing question rather than something that needs to be remembered separately. Number 7. Anticholinergic bladder medications with oxybutynin among the most commonly prescribed, used for overactive bladder and urinary urgency. Like the antihistamines we discussed earlier, oxybutynin works partly by blocking acetylcholine, and it crosses into the brain relatively easily, which is part of why it also appears on the Beers criteria list for older adults. Research, including a widely discussed study in the BMJ, has associated long-term use of strong anticholinergic medications like this one, though with a meaningfully higher relative risk of dementia diagnosis in older adults, a genuine area of concern in geriatric prescribing. Even though, as with other observational research, it doesn't establish direct causation on its own. If you take a medication like this and have noticed changes in memory or focus, that's worth raising directly with your doctor. There are other approaches to overactive bladder that work through different mechanisms and are generally considered to carry less of this particular risk. But which option is right depends on your specific situation, which is exactly why this is a doctor conversation, not a video conversation. It is worth adding that overactive bladder itself is a real and often under-discussed quality of life issue, and nobody should feel they have to simply live with it untreated out of fear of this research. The goal here is an informed conversation about options, not avoiding treatment altogether. Number 6 may be the most surprising entry on this list, because it's one of the most widely prescribed medications in the world, statins, including simvastatin and atorvastatin. Statins lower cholesterol and meaningfully reduce the risk of heart attack and stroke for a great many people. This is important context because concerns about statins and cognition have been studied closely, and the picture that's emerged over time is more reassuring than early reports suggested. The FDA reviewed this question directly after early case reports raised concern, and updated statin labeling in 2012 to note reports of memory issues, while also stating that the available evidence did not support a clear, established link between statins and serious, lasting cognitive decline for most people. Some individual studies since then have suggested a possible association in specific subgroups, while others, including large reviews, have found no meaningful effect, or even a slightly protective one. The honest summary here is that the evidence is genuinely mixed and still being studied. This is a case where the popular narrative online has often run ahead of what the research actually supports. If you've noticed cognitive changes while on a statin, it's absolutely worth mentioning to your doctor. But this is not a medication to stop out of fear, given how well documented its cardiovascular benefits are. It is worth remembering, too, that untreated high cholesterol carries its own well-documented risks to long-term brain health, since cardiovascular health and brain health are closely connected. Stopping a statin out of an overstated fear of cognitive risk could trade a well-established benefit for a much less certain one. For context on scale, cardiovascular disease remains a leading cause of death and disability in older adults, and the evidence supporting statins for appropriate candidates is considered some of the strongest in all of preventive medicine. This is part of why the reassuring FDA review on cognition mattered so much when it came out. Quick pause. If this is helping you think through your own medication list, subscribing helps this channel keep making videos like it, and I read every comment. Number 5. Benzodiazepines, lorazepam, diazepam, and alprazolam among the most familiar names, commonly prescribed for anxiety and sleep. These medications work by enhancing GABA, the brain's primary calming signal. In the short term, they can genuinely help with acute anxiety or a difficult stretch of insomnia. Longer-term use is a different picture. Some research has associated extended benzodiazepine use in older adults with a higher rate of dementia diagnosis. Though this remains a genuinely debated area in the research literature, several large studies have raised the question of whether early, undiagnosed dementia symptoms like anxiety and disrupted sleep lead to a benzodiazepine being prescribed in the first place, rather than the medication causing the decline. Researchers describe this as a difficult causation question to fully untangle. What is well established and matters far more urgently is this. Stopping a benzodiazepine abruptly after regular use can be medically dangerous, including a real risk of seizures in some cases. If you've been taking one of these regularly, please do not stop suddenly under any circumstances. Any change needs to happen gradually, under a doctor's direct supervision. If long-term use is a concern for you, the conversation to have with your doctor is about a slow, supervised taper over weeks or months, alongside other approaches to anxiety and sleep that may be available. This is one of the clearest examples on this list of why professional guidance matters more than any single piece of information in a video. It is also worth noting that benzodiazepines are sometimes prescribed for a short, specific period, before a medical procedure or during an acute crisis. And that kind of short-term, occasional use carries a very different risk profile than years of continuous daily use. Context matters enormously with this particular medication class. If a taper is underway, it is worth knowing that many people describe the first few weeks as the hardest, with gradual improvement after that as the body adjusts. Having support in place, from a doctor and often from family, tends to make a meaningful difference in how manageable that period feels. It is also worth knowing that for some people, the anxiety or sleep issue that originally led to the prescription may have genuinely improved over the years, meaning a taper is not just about reducing risk, but about no longer needing the same level of medication in the first place. Number 4. Amitriptyline, an older generation antidepressant still widely prescribed today for nerve pain, migraine prevention, and sleep, largely because of how many different things it's used for. Amitriptyline is also one of the more strongly anticholinergic medications still in common use, meaning it blocks acetylcholine quite significantly, the same chemical pathway we've discussed with several other medications on this list. Research, including a frequently cited study in JAMA Internal Medicine looking at cumulative anticholinergic exposure over time in older adults, found an association between higher long-term exposure to medications like amitriptyline and increased dementia risk. Again, an association worth taking seriously, though not proof of direct causation in every individual case. If you take amitriptyline for nerve pain, migraine, or sleep, it's genuinely worth asking your doctor whether a lower anticholinergic burden alternative might be appropriate for your specific situation. There are other options available for each of those uses. But this, like everything else on this list, is a conversation to have with a prescriber who knows your full medical picture, not a swap to make on your own. One additional detail worth knowing. Amitriptyline is often prescribed at a much lower dose for nerve pain or sleep than it would be for depression, and some research suggests the anticholinergic burden may scale with dose. This is another detail worth raising directly with your doctor, rather than assuming a fixed answer applies to everyone. For nerve pain specifically, physical therapy and certain topical treatments are sometimes used alongside or instead of oral medication, depending on the specific type and cause of the pain. Another reason this is worth a detailed conversation with whoever is managing that particular condition. Number 3, the one worth paying particular attention to, because it's prescribed for something that sounds entirely routine. Paroxetine, an SSRI antidepressant used for depression and anxiety. Most SSRIs have relatively low anticholinergic activity. Paroxetine is a notable exception among commonly prescribed SSRIs, with meaningfully more anticholinergic effect than others in its own drug class, which is part of why it's included on the Beers criteria list specifically for older adults. Research looking at cognitive outcomes across different SSRIs has found more measurable short-term memory and attention effects associated with paroxetine specifically, compared with other SSRIs studied in the same research. If you currently take paroxetine, this is worth a specific conversation with your prescriber, not because SSRIs in general are a concern, but because other SSRIs with a lower anticholinergic profile may be appropriate alternatives depending on your history. As always, any change to an antidepressant needs to be planned and supervised by your doctor, since stopping or switching abruptly can cause its own difficult symptoms. It is also worth saying plainly that untreated depression and anxiety carry serious risks of their own, and no one should stop an antidepressant out of fear without a clear plan in place with their doctor. The goal here is a more informed conversation about which specific SSRI might fit best, not stopping treatment altogether. It is worth knowing, too, that switching between antidepressants is a process doctors are quite experienced with, often involving a careful overlap or taper rather than an abrupt stop and start, specifically to minimize discomfort during the transition. And it is worth remembering that everyone responds differently to specific SSRIs. What works well for one person may not suit another, which is exactly why this remains an individualized medical decision, rather than a one-size-fits-all swap. Number 2, and this is a genuinely important one to get right. Antipsychotic medications, including quetiapine, risperidone, and olanzapine. These medications were developed and remain essential for serious psychiatric conditions, like schizophrenia and bipolar disorder. And for people managing those conditions, they are often a critical, carefully monitored part of ongoing treatment. Nothing here is a suggestion to question a medication prescribed for a primary psychiatric condition. The specific concern raised in geriatric research relates to a different, narrower situation. These same medications sometimes being used off-label in older adults, particularly those with dementia, to manage agitation or sleep disturbance rather than a primary psychiatric diagnosis. This specific use is significant enough that the FDA has placed a black box warning, its most serious safety label, on these medications specifically regarding elevated mortality risk when used for dementia-related behavioral symptoms in older adults. This is well-documented, official guidance, not a fringe claim. If a loved one has been prescribed an antipsychotic specifically for agitation or sleep related to dementia, rather than for schizophrenia or bipolar disorder, that black box warning is worth discussing directly with the prescribing doctor, including whether non-medication approaches like routine, reduced overstimulation, and addressing underlying pain or sleep issues have been fully explored first. This is a decision for the medical team and family together, never a video. It is also worth being clear that discontinuing an antipsychotic prescribed for schizophrenia or bipolar disorder without careful psychiatric supervision can lead to serious relapse. This entire discussion applies specifically and narrowly to off-label use for dementia-related agitation, not to primary psychiatric treatment, and that distinction matters enormously. Family caregivers in particular are often the ones who notice behavioral changes first, and are well positioned to ask the specific question of why a medication was started and whether it remains the right fit. A conversation that geriatric specialists generally welcome, not resist. One more quick note. If you're finding this useful, subscribing genuinely helps the channel. And I do read the comments. And now, number 1. And it isn't a single medication at all. It's the combined effect of several anticholinergic medications taken together, often without anyone adding up the total. This is sometimes described using the idea of anticholinergic burden, the cumulative effect of multiple medications that each block acetylcholine to some degree, even if each one individually seems mild. Picture a common, realistic scenario: an antihistamine at night for sleep, a bladder medication during the day, and something like Amitriptyline for nerve pain. Each one alone might have a modest effect. Combined, geriatric pharmacology research suggests the cumulative burden on the brain can be considerably larger than any single medication would suggest on its own. Research in this area, including large observational studies tracking anticholinergic burden scores over time, has associated higher cumulative burden with meaningfully increased dementia risk, a large enough effect that it's taken seriously in geriatric medicine, even accounting for the usual caveats about observational research. Here's the genuinely encouraging part, and the reason this tops the list rather than any single drug. When it's identified early, some medication-related cognitive change appears to be at least partially reversible, reducing unnecessary anticholinergic burden under medical supervision has been associated in some studies with meaningful improvement in cognitive symptoms over weeks to months. The practical step here doesn't require a specialist or a complicated process. It requires a conversation. Bring every medication, over-the-counter product, and supplement you take to your doctor or pharmacist and ask directly about your total anticholinergic burden. Tools exist specifically to calculate this, and many pharmacists are well equipped to walk through it with you. It is worth mentioning that some pharmacies and clinics now offer a formal medication review service specifically for this purpose, sometimes called a brown bag review, where you bring in everything you take, prescription and over-the-counter alike, for a comprehensive look together. It is worth adding that this kind of review tends to be most valuable when done periodically, not just once. Medications get added over years by different doctors for different reasons, and nobody outside of you and your pharmacy has the complete picture unless someone actively puts it together. Some clinics now use standardized anticholinergic burden scoring tools during routine visits specifically for patients over a certain age, which is a promising sign that this concern is increasingly built into everyday care rather than left to chance. Let's bring this together. Several of the medications we've discussed today are genuinely important, appropriately prescribed treatments for real conditions. None of this is a reason to panic, and none of it is a reason to stop anything on your own. What the research broadly supports is this: periodic medication review matters more with age, particularly for anything with anticholinergic activity, and particularly when several such medications are being taken together. That review belongs to you, your doctor, and your pharmacist, not to a video, however carefully sourced. It is also worth remembering that every person's situation is different. The same medication that causes noticeable fog in one person may be perfectly well tolerated by another, which is exactly why individualized medical guidance matters more than any general list, however carefully researched. One essential note before we close. I'm David Morgan, an AI-generated health educator, not a licensed physician, pharmacist, or psychiatrist. Everything in this video is general, source-checked information, not personal medical advice, and it should never be used to start, stop, or change any medication on your own. Several of the medications discussed today, especially benzodiazepines and antipsychotics, can carry real risk if changed abruptly or without medical supervision. Please bring any questions this video raised directly to your doctor or pharmacist, who knows your full medical history in a way no video ever can. If this helped you think through your own medication list, let me know in the comments. And if you're planning to ask for a medication review this week, Tell me that too. I read every comment. Next time, we'll look at something a lot of you have asked about. What changes in your fingernails are actually worth paying attention to, and which common claims about them are overstated? I'll see you there.